So we are live in 5, 4, 3, 2, 1. We are live now.
Good evening, everybody, and welcome to this second webinar from Arthroscopy Insights. The first one, as some of you will remember, was on shoulder instability, and we had a stellar faculty with Dr. Vivek Pandey, who has joined from Manipal, and Dr. Nilesh Kamath from Pune, and Shirish Pathak from Pune. And at that time, we had also circulated a very good article on shoulder instability and followed that up with the webinar. We got a very good response. So keeping the same in mind, we thought of taking the second webinar on hidden lesions for Arthroscopy Insights. And today I'm very happy to share that we have again a very excellent faculty. We have Dr. IPS Oberoi from New Delhi, plus we have Dr. Rajeev Raman from Calcutta, and we have Dr. Gopinathan from Calicut. So these three people who have a great experience in arthroscopy of the knee will be giving us talks. Dr. IPS will speak to us about ACL with ramp lesions. Dr. Rajiv will speak to us on ACL with PLC, what is the decision-making plan, and Dr. Gopinath, who has just joined us, will be speaking on the anterolateral ligament along with ACL, which is a hot topic. And for this, to moderate the sessions, we have Dr. Nicholas Antao, who is my mentor and who was my president when I was the secretary of Indian Arthroscopy Society, and Dr. Roshan Wade from Mumbai, who needs no introduction. And next week, he's going to have a great meeting on arthroscopy under the platform of Arthroscopy Academy, and we will soon hear from him. So before Dr. Nicholas Antao takes over, I want to welcome Dr. IPS Oberoi, Dr. Rajiv, and Dr. Gopinath. Thank you for joining us. And Dr. Roshan, if you can quickly tell us a little about your meeting, and then I will ask Dr. Nicholas to go ahead. The format will be about 10 to 12 minutes talk, followed by question answers. And first we'll be starting with IPS. Over to Roshan. Mute.
You are muted, Roshan boss.
Yeah, thanks Parag for wonderful opportunity. I think this Arthroscopy Insight is a very promising group for young people who want to learn everything about arthroscopy and sports medicine. We will learn from our own colleagues and friends and seniors. So I think it's a better opportunity. At outset, I'd like to thank everyone for inviting me. And let's proceed with the scientific agenda for today's meeting. So I think first
do you
speaker
want to
is
quickly
Dr.
say about the Arthroscopy Academy meeting?
Okay.
Really very
So,
few registrations are left.
Yeah, so I think we are planning to have this meeting. This is the 11th meeting of Arthroscopy Academy, which will be here from 19th June to 22nd June. 22nd June is a cadaveric course. So 19th, 2 o'clock, we are starting meeting. We are around 20 live surgeries and 2 orations, as well as around 13 panel discussions with 6 debates. So I think it's a very good mixture of academic as well as a live demonstration by senior faculty. So I request all of you to attend this meeting. If possible, you can connect to our event manager. That's a Vama event who will help you in registration. Without any delay, I think we should proceed with the scientific agenda. I'll request Dr. IPS Oberoi. IPS, can you hear us?
Yeah. Before that, if
Let's
Dr.
start.
Nicholas Antao can say a few words.
Yes.
Yeah, Dr. Nicholas Antao.
Yeah.
Dr. Antao.
Very good evening to all the faculty and organizers, Dr. Parag and Dr. Ashok Shyam. I thank you all very heartily for getting me as a moderator. I remember last time I heard the ramp lesions. I had to go all the way to South Africa to hear IPS Oberoi. Can you imagine that? Yes, you remember? All right. So I won't take much of your time. So that will be interesting. And I thought the lesions have expanded now and the causes have also expanded and the risk factors are also expanded. So I know for sure you will enlighten us with your presentation. Over to IPS Oberoi, the pillar of arthroscopy of India.
So I share the screen. You can see the.
Yes, we can see your desktop.
Busy desktop. Lots of money on it.
No, it's just starting now.
Perfect.
Let's go to play. Yeah. So things are clear?
Yes.
Thank you. So we talk about ramp lesions. I think ramp lesions are pretty common lesions which were missed previously because information about ramp lesion was not much in literature. This essential lesion is a meniscocapsular or a meniscosynovial lesion, which happens on the posterior aspect of the meniscus on the medial side. And the incidence has been reported between 9.3% to around 17% in ACL deficient knee. Now, what happens in an ACL deficient knee? A chronic tear of ACL keeps on having anterior instability, which causes a lot of forces on the posterior part of the meniscus, leading to this tear, which is called as a ramp tear, happening due to anterior subluxations in a chronic ACL deficient knee. It's also important that when you have an ACL deficiency associated with ramp tear, and we don't treat a ramp, we just do a ACL reconstruction, the ramp lesion will persist and the graft will have excessive translation which will happening on the graft, will result in graft failure as well. So it's both way. If you have a chronic ACL tear, ramp lesion is a sequelae of that. And if you don't treat a ramp lesion, your ACL is going to fail in almost all these cases where there is a significant ramp lesion. So identifying this ramp lesion are practically important. And we tend to miss these ramp lesions because sensitivity on the ramp lesions on an MRI is not so great. Our MRI is done in full extension. This reduces the meniscocapsular separation and you won't be able to see a ramp lesion. But if you see very, very clearly, there would be a sequence, which is a white sequence on a T2 image, which will show that there is some problem out in the posterior part of the meniscus there. And this is essentially a ramp lesion. To be sure that ramp lesion is there, I think it's important to do an arthroscopy wherein you put your telescope between the PCL and the medial femoral condyle and go over the top position to see the back of the knee. I think this kind of maneuver, which is a Gilchrist view, is very, very important to see for a ramp lesion. Going between the medial femoral condyle and the PCL, when you take your telescope back, you're able to see the meniscocapsular separation if it is there. And I think bringing your knee into a valgus and rotation will help you in opening this area of the knee so that you are able to see. The gold standard, however, is essentially probing and directly palpating the ramp lesion. And this would happen essentially if you are putting a small needle from the posterior-medial portal. So we always, in a ACL deficient knee, do a posterior-medial portal through transillumination and then make a small stab incision and put a probe there essentially to see for the ramp tear in that area. And think palpating the ramp lesion is important because ramp lesions could be minimally unstable, which does not need any surgery, but there could be an unstable ramp lesion, which essentially would need a fixation. So direct probing is the gold standard to diagnose a posterior ramp lesion. And this would happen on a posterior medial portal as such. Now there are tears which could be smaller. This could be up to 1.5 centimeters without gross excursion, which means they are not unstable. They are stable tears, and we don't need to stitch these stable tears. So when we put a small needle, we palpate these tears, and if we think these tears are small, we just debride it with shaver or with the help of a rasp or with a trephine, and the vascularity in that area will help the ramp lesion to heal itself. And most of these small tears actually heal themselves. The problem happens if the tear are larger. So that is a tear which is around 2 centimeters or so. And these are tears which will have excursion or a gross instability. So we have gone through a trans-notch view, which I said a Gilchrist view. And we are probing now from the posterior medial portal, putting a small probe. And we feel that this is a large tear which is extending from the periphery all towards the central. And this is going to cause a lot of pressure over the ACL. So we need to fix it up. To fix the ramp tear, what happens is that whenever there is a meniscocapsular separation, the capsular side falls down. So with help of a lasso, which is a curved device, you first need to lift the capsular part. Once you've taken a bite into that, you do a second bite into the posterior part of the meniscus. So the bite in the first part goes in the meniscocapsular area, and second bite goes into the posterior part of meniscus. And then you can tie a knot. The the knot will be towards the capsular side, not towards the meniscal side. So that's a knot towards the capsular side. So this is a tear, which is an unstable tear. And what we are repairing essentially is putting a telescope through the Gilchrist view and putting stitches from the back of the knee, a bite into the meniscocapsular area and second bite into the meniscus, and then tying a sliding knot on towards the capsule side. And this is how we treat a 1.5 centimeters up to 2 centimeters of an unstable ramp tear. But sometimes the ramp tears are larger than that and they are pretty unstable. And in these cases, the technique of doing a ramp repair essentially is not from the front, but from the back, which means that now we have to make a high posterior medial and a low posterior medial portal. So these are two portals on the medial side, which will help us in taking bites and doing suture management as well. And there, the scope will also be going from the front to the back. This is called a transseptal view. So if you see here, there is a transseptal view. Our telescope is in the lateral side of the knee. The septum has been taken down. On the medial side, we are putting a high portal on the upper side, which is a high posterior medial portal, and a low posterior inferiorly, which is a low posterior medial portal. With the low posterior medial portal, we are taking bites into the meniscus as well as capsule. We start from the periphery, and the suture management is done by high posterior medial portal. So if you see, we are actually taking sutures out and then taking another bite. So the scope is not in the front, but scope is in the back. In this way, we are able to see the whole length of the ramp tear, and we can start taking bite one by one, starting from the periphery, going more towards the center. So that's the second one. And now it is a third one. With the ramp lasso, the bite is in the capsule and bite is in the posterior part of meniscus. A suture is shuttled. And now we have 3 sutures, which are on the medial, second, and the third is the lateral. And then we start tying knots from most of the medial part. So that's a sliding knot which we are tying. The scope is in the posterior lateral portal. We are putting the knots on the capsular side. That's the first knot. Then we put the second knot as well as the third knot. So these are knots which are put towards the capsular side. It raises the posterior part of the capsule, brings the posterior capsular junction together and help us in treating this ramp lesion nicely. So when you have a large ramp lesion, it is a good idea to actually bring your scope from the front to the lateral part, the posterior part, and then see the extent of the ramp tear, and then start stitching from the periphery towards the center, putting knots to the meniscocapsular junction. So for a large tear, always we take our scope from the front, from the Gilchrist view to the posterior part, and do what is called the transseptal approach. Finally, surgical tips which are important when you treat the ramp tear lesions. As you saw, the distance between each of the sutures is between 7 to 10 millimeters. So roughly centimeter of a gap between these. We just put simple vertical mattress repairs. We start working from the medial to the lateral side, and the sutures are tied in knee in mid flexion. And as I showed you, the knots are kept towards the capsular side. It's important to have these 2 important things when you do a ramp repair. Number 1 is when it's always pertinent to make a posterior medial portal. There is a saphenous nerve and a vein which is in the back, and transillumination helps us in avoiding any injury to the vein. Vein and nerve are very close by. So when you do a transillumination while making a posterior medial portal, you are able to protect that vein from getting injury. And you just give a small stab incision in the skin, and then with the mosquito, open the posterior medial portal. Number 2, because ramp tear is a vascular area, it is going to heal. But you need to brace these patients when you do an ACL reconstruction with them. We limit their range of movement to around 50 degrees, 50% or so in first couple of weeks, and slowly increase their range of movement because you don't want to stress more on the ramp lesion which you have repaired. So final protocol essentially is like that. As I was telling you, if it is small tear up to 1.5 centimeters, which is grossly stable tear without gross excursion, we would just refine, debride with a shaver and leave it like that. It will heal. If it's a moderate kind of tear up to 2 centimeters or so, which is unstable, our telescope goes through trans notch view. We make 1 posterior medial portal and do what is called as an all-inside repair. But if the lesion is larger with grossly unstable lesion, we go with a transseptal approach. Our telescope goes to the lateral part, and on the medial side, we make 2 portals, 1 superior high posterior medial portal and 1 inferior posterior medial portal, and then do an all-inside repair. It's pertinent to protect and brace these patients in the post-operative period. Understand very well, these are hidden lesions of the knee, and we need to look for these lesions. So on an ACL deficient knee, always look for a ramp lesion. 10 out of 10 cases, at least 2 or 3 cases, you will be able to see a significant ramp lesion. Posterior medial portal is important. Almost all chronic ACL tears, we make a posterior medial portal, usually first with a needle and palpate the ramp area. And when in doubt, make a small stab incision and put a probe and palpate it. Importance of ramp cannot be undermined. It is an important lesion. When you repair this lesion, it actually protects your graft from excessive forces, which means the failure rate of ACL reconstruction will come down very, very significantly. Learn the transseptal technique. I think it's very, very important to do a transseptal technique in a large ramp tears and try to make a high posterior and a low posterior medial portal for suture management. It makes your life much more easier. So these are hidden lesions of the knee. The more you try to find them, the more you will be able to understand and see these lesions of the knee, and you won't miss it. Thank you very much.
Thank you, IPS. That was a wonderful talk on ramp. So, anybody has any question for discussion? Dr. Antao, Nicholas Antao?
Excellent talk, IPS. I have two questions. So, as you rightly said on the MRI, it is not really picked up, and you see it during scopy. So, are there anything which we should tell our radiologist to specifically look for during the MRI? Because even we have missed this, and I have missed it in my own hands. And once it became known, then we started looking for it. But for the MRI, any tips on what to tell the radiologist?
I think, Parag, like in the root lesions where we see a lot of edema in that area in the posterior part of the meniscus, even in the ramp tears, if you're able to see some edema in that area, especially on the tibial side and the posterior capsule, even if there is no split or a clear demarcation of a ramp tear, your suspicion rate should be high, especially in a chronic ACL deficient. So in these patients, I think whenever you find such kind of edema in the posterior part of the tibia, always during arthroscopy, palpate that area.
Okay.
Right. Antao, sir.
IPS.
Yes, sir.
Do you ever use a 70-degree scope to see this lesion?
Yes, sir. I think 70-degree scope is very, very useful, especially when you have a ramp tear which has fallen down, and just going through Gilchrist view, you might miss it. So there are two important tips. One tip, as you said, is a 70-degree scope. The second is, once you make a posterior medial portal, you may as well shift your telescope to the back of the knee in the posterior medial side and have a direct look into it. So for those who are beginning to work in the posterior part of the knee, the idea is good to shift from a 30-degree into a 70-degree scope and go through a Gilchrist triangle, that view, and then possibly the chances of missing ramp lesions are much less. So I agree with you, sir. That's a good idea.
How often do you use a transseptal portal? I mean, ligamentous portal, in the sense between ACL and PCL?
Not very common, sir. Most of these lesions are smaller lesions which can easily be approached by a single posterior medial portal. So just put a cannula in the posterior medial portal, and with the help of a lasso or a suture passing device, most of these small lesions can be treated. The bigger ones are those which are actually extending all the way from the peripheral part into the central part. When there is a huge amount of traction which happens in these patients because of semimembranosus pull, the gap between the capsule and the posterior part of meniscus becomes large, and that whole part of the capsule actually falls down. And in that area, probably just posterior medial portal might not work. And then we have to do a transseptal, going through the lateral, looking down, and then possibly stitching from one side to the other. Not very commonly that we do transseptal, but yes, once in a while you need to do that.
Add here, in case, if you allow IPS, addition, how to diagnose ramp, which I think Rom Laprade, when he visited Goa and Jaipur, both places, in Goa, he decided to demonstrate his own sign. That is, when he puts his scope in Gilchrist portal and he takes a needle, and he, with that strong spinal needle, he tries to lift the capsule. The moment you are able to lift the capsule up, that means there is a capsular lesion. That's one. Second, he described in Jaipur was anterior translation of tibia. So what it does is he puts his scope posterior, and then he does an anterior drawer test. So the moment you do anterior drawer test, the capsular separation is very prominent. So this two maneuvers he has described for diagnosing ramp on table. And coming back to Parag's question, is MRI diagnosis of ramp is possible? Is very much possible. The only thing is it depends on the number of days from your primary injury. If it is done very quickly, if there is associated ramp, you can see the natural arthrogram created by blood flow. If you do it later date, the blood usually gets resorbed and you can't see the ramp lesion. Then you have to do it in a knee coil. That knee coil should have an anterior translation. There is an importance given to PDTS system described by Dr. Jao Mendes from Porto. They have described this patient distraction system for MRI. You can literally see the upper translation of tibia as you see in your ACL injury. So I think these are 3-4 things which everybody has to learn.
Yeah, there is some classification of the MRI, no, IPS.
Yeah.
He classified that into 4 types. And do you follow that?
No. So the problem is that the MRI, most of these patients actually bring their MRI, and you are not able to actually identify these lesions very often. So what our bottom line is essentially, as Roshan was rightly saying, direct palpation of the lesion whenever there is suspicion. So when you directly put a needle there and palpate these lesions, you can unmask these lesions, because most of these lesions are covered with synovial tissue, and MRI won't be able to be so very sensitivity. Sensitivity has been reported between 0% to around 70% or so. So there is huge amount of variation in that. Direct palpation is the right way to diagnose, and just putting a needle and palpating is a very good technique. And secondly, I think as Roshan said, scope into the posterior portal, do an anterior draw, seeing how the capsular shift is happening is again a very good sign. And both of these will give us a direct indication.
Sir, coming back to the classification, Dr. Sheetal Gupta from Bhopal, he has proposed a zip lesion of ramp with meniscal tear. So that's an additional of type 6 and type 7 lesion of ramp.
So if you can share that with me, Roshan, we'll put it on the Arthroscopy Insights group.
Complete article
One more question to you, IPS.
Yeah.
You spoke that if the lesion is up to 2 centimeters, we can repair it by the all inside technique. So for this all inside, do you go by the posteromedial portal and other sutures? The all inside is the device is passed through the regular anteromedial or anterolateral portal.
No, it's a posteromedial portal. What happens?
The all inside device goes through the posteromedial.
Posteromedial portal, because what happens is the capsule actually falls down, and if you access to the front, you are able to only palpate and pierce the meniscal part, not the capsule, because capsule part has gone down. Now, when you go from the posteromedial portal, you are able to lift the capsule up, and that is a maneuver which is important. So once you take first stitch and lift the capsule up and stitch it, sometimes second bite you can go from the front as well, because now the capsule tissue is floating right in front.
But if your all inside device is from the posteromedial portal, you have to complete it the first bite, withdraw second bite.
It's not an all inside device. I mean, the technique is all inside. But
so you're not, it's not the all inside device which we use, for example, fast fix, 360 or ultra fast fix. So those are not usable.
The technique is all inside because you are just going all inside. But you're using lassos rather than your fast fix.
That I understood. That you demonstrated so well. It was very beautiful. So, but if we take the all inside and pass one stitch to the inferior part, withdraw and pass to the superior part, and then tighten it like we do in a radial tear, will that work? I've never tried it, but I just wanted to ask you.
I'm not very sure. The capsule tissue is pretty thin there. And as Roshan said, sometimes it is an acute injury. So sometimes these are small, like a peak. They may not actually, it may pull out. Taking a nice bite is absolutely
essential. That's a very robust way to repair it.
And it is because of the pull of the semimembranosus. So there is a huge amount of traction which has happened to that area. I think it's the big bite are much important in that.
Yes. Rajeev, you want to say something? Looks like Rajeev, and then
I think Sometimes we use the knee scorpion also to take bite
Yeah,
from the capsular side. I
that's
think
all.
that is
That's a
a
good
very
idea,
good bite.
Rajeev, because
That's
that
a
gives a
very
big
good
bite. So you can use a knee scorpion to
bite.
No, but
Okay.
Yes.
problem with knee scorpion is you can take one side capsular bite, but the
Yes, yes.
meniscal bite taking through knee scorpion is a big problem.
Yeah.
No,
From
no.
posterior.
On the capsular side, I think it gives a good access.
I feel what
Okay.
IPS has demonstrated, the lasso is a wonderful system for your ramp. And at least one bite through lasso will, it's like a bankart,
Yeah.
bankart, you cannot achieve bankart repair unless you go just beneath and take that capsule from the glenoid neck. So unless you do that, you cannot get a very good shift.
Right.
IPS,
Yeah. Yeah. Definitely.
do you have some clinical suspicion when you examine the patient that this is having a ramp lesion?
So in a ACL deficient knee, sir, if there is an explosive pivot, believe
That's
me,
it.
ramp lesion is very, very common. So explosive pivot, ramp lesion is very, very common.
Anything about the condyles and all?
Yeah, some edema. If you have a deep lesion on the lateral condyle, which is essentially called as a Hill-Sachs lesion of the knee. So like we have Hill-Sachs lesion of the shoulder. If you see a Hill-Sachs lesion of the knee, again, that is an indicator of a gross instability, and possibly a ramp lesion would be on the opposite side.
Okay.
Okay. If there are no more questions.
There are questions, but we'll go ahead.
Yeah. Let's move it to 5:30,
Yeah.
I think.
Yeah.
Rajeev.
But thank you, IPS. Great talk. We now move to Rajeev Raman, who has a great experience in arthroscopy, and he will tell us about ACL and PLC. Yes, Rajeev, what is your decision making
Yes, sir.
protocol?
PLC injury. Thank you, Parag sir, for wonderful initiative. So I will be talking on decision making in PLC injury. So if you see the posterolateral corner, now it's no more a dark corner of the knee. We have understood the biomechanics, and there are three important pillars which we should take in concern when they are planning for decision making in posterolateral corner injury. The first one is your fibular collateral ligament, the popliteus tendon, and the popliteal fibular ligament. And how they works. If you see the FCL, it's a primary static stabilizer to the varus opening. And this is very important, one of the important stabilizer of your lateral posterolateral corner. If you see the biomechanical study of popliteus, it's a primary static and dynamic stabilization to the posterolateral rotation of the knee. So it's a very important posterolateral stabilizer, rotational stabilizer of the knee. And if you see the popliteofibular ligament, it's an important stabilizer for the external rotation of the knee. So this popliteus and popliteofibular ligament gives a rotational and external rotation stabilization to the knee, and the varus stabilization is by your FCL. So what is very important in assessment of this posterolateral corner injury, whether you are dealing with an isolated LCL tear or a posterolateral corner where you have a complex tear involving all these three important pillars of the posterolateral corner. So just I will go with two clinical scenarios. So you can see this is a patient of 35-year male, pain and history of giving way in the left knee for 6 months, and a transtibial ACL reconstruction was done 1 year back. And again, the patient came with the symptoms of instability, and we saw that the post-dial test is positive. It was the posterolateral corner injury which was missed, and that was the reason for the instability, the failure of reconstruction of the ACL. So what we planned, and if we can see the patient has a Latchman positive, and you can see the dial test was positive, almost 70-degree external rotation on the affected side. So what we planned for a ACL reconstruction with the, you can see here, because peroneus graft, and the PLC reconstruction with the modified laparoscopy. Normally, I do it in the hanging position. So your incision starts from 6 centimeter above the lateral epicondyle, in between the fibula head and the Gardis tubercle. So try to get a thick posterior breast flap, and this is very important, and go for neurolysis of the common peroneal nerve. So once you dissect posteriorly, what is the common thing which is important? Identify the long head of the bicep femoris, and just start dissecting the CCP and proximal to distal. This will help you because it's very loose in this part. neurolysis of your common perineal nerve. So once you have dissected this common perineal nerve, the next important step is your first window at the level of lateral femoral epicondyle. And this is very important because this window, through this window, you can identify your FCL, you can identify your popliteus tendon. So you can see the lateral epicondyle, and you just dissect this window proximally and distally so that you can identify the FCL and the properties. Now you make a fibular tunnel. It's from anterolateral to posterior oblique tunnel, starting lower and at a 30-degree caudal, and at least 1.5 centimeter from the tip of the fibula. You can use your ACL jig or you can use your finger also to just. But when you are using your finger, try to drill with your own hand and fast your first color suture. I always prefer putting my color suture in different tunnels. So this is your fibular tunnel. So once you have made your fibular tunnel, next is your tibial tunnel. So try to populate the popliteus groove in the posterolateral aspect of the proximal fibula, and try to drill from the Gardis tubercle at least 8 to 9 millimeter below the tibial plateau. And you can see now you have drilled your tibial tunnel. Now identify, this is the pull-out technique by which I identify my FCL and the LCL, the popliteus and the FCL. So this is very important. So you can make two-take tunnel as per Laprade technique, or you can use a single tunnel in between your FCL and your popliteus insertion. So whenever you are planning for a revision ACL or something like that, I usually prefer a single tunnel to avoid collision of so much tunnel in the femoral condyle. The direction of the tunnel should be caudal, and it should be direct toward the superior pole of the patella. Then you pass your graft in the femoral tunnel first. Once you have passed your graft in the femoral tunnel first, then you have two limb of the graft, a smaller limb and the larger limb. So you can either pass it through the femoral tunnel or tibial tunnel first, and try to pass it through the first window underneath the iliotibial band. So before that, always fix your graft and see your graft should be solid enough, and see you can fix it either with a metal screw or a bias screw. Nowadays we are using adjustable loop also to fix it over the femoral side. So once you have fixed it to the femoral side, see for the stability of the fixation, and then you see this graft is quite stable over your femoral side fixation. Now pass your graft underneath the iliotibial band. So one band will go from the underneath the iliotibial band, another graft will go from the iliotibial band under the from the fibular head, and try to take both the graft towards the tibial tunnel. So once you have taken it toward the tibial tunnel, you can see now you can fix it at 60 to 70 degree of knee flexion. Now this is very important. When you are identifying, ask your assistant to give a bit of anterior dot, so that whenever there is a posterior subluxation of tibia, you can refer. You see the assessment of the stability. This is very important at the end of the procedure. The second group of the patient is a soccer player, has a pain and giving way of the left knee, and he has a posterior dot test positive and various tests are negative. And if here you can see on the MRI, this is a complete PCL plus a LCL tear. And here you can see the posterior door test is positive. Sorry, I think this video is not running. So, and the varus test is positive. You can see here, it's a varus test which is positive. So, dial is negative. So, these are the scenario where you can come out with the fibula-based procedure. You don't need to go for a tibia and fibula-based procedure. Just fibula-based procedure is good enough. So, again, it's the same incision. Try to make a posterior-based flap and dissect your common perineal nerve as I have described in my previous talk. And once you have dissect your common perineal nerve, the next step is making of your femoral tunnel. Again, I use a tag technique, suture tag technique. So you identify your LCL, identify your popliteus, and try to make a single tunnel in between them. So once you have made your femoral tunnel, then the same way you pass your graft to the fibula end, and at the end of this gives a good varus stability. So this is very important. What you will plan and how will you plan for when you get either a ACL or a PCL injury with the posterolateral corner injury. So this is a very simple algorithm I prefer. Is the one group of patient you have dial test positive and the varus test is positive. These are the ideal patients for your laparade procedure, tibia and fibula based procedure. The another group of the patient, you have a dial test positive and virus negative. I think you can come out with the popliteal sling procedure. And the third group of the patient is a very common, a dial negative but virus stress is positive. I think these are the patients where you can plan for your fibula based fibula sling procedure, either a Arserio or a Larsen procedure. Thank you so much. I think now we will have question answer on posterolateral corner.
Yeah, so great presentation. Nicholas, sir.
Rajeev, very good presentation. Do you ever do this
Thank you, sir.
percutaneous?
Speak little loudly.
Sir,
do you
Nicholas,
ever
sir?
do this percutaneous?
Sir, once I started percutaneous, but once I burnt my finger, had a CPN palsy, so I have stopped doing percutaneous. So most of my posterolateral corner injury, I do it as an open method. So open procedure, sir. I don't prefer percutaneous.
Okay, thank you.
Percutaneous is what technique? Percutaneous is what technique?
You remember during the COVID, the Barcelona doctor, I forget his name, had taught to us. Yeah.
Yes, and Bancha also does. Percutaneous is like just a small incision over the lateral epicondyle Roshan boss and a proximal fibula. You pass the graft, you are not dissecting the CPN nerve. So I think it's always better, and I think it's always preferable to dissect your common peroneal nerve, because sometimes what happens, you have some anomaly also there. So if you drill through that, or you are very close to that, the chances of neuropraxia of common peroneal nerve.
If a single message, this arthroscopic insight video, has to pass on today, it is that never attempt a compromise work on lateral side.
Yes,
the peroneal nerve is a major motor nerve. Damage to peroneal nerve is 100% disaster.
Yes, never. I never prefer percutaneous. Never.
Whatever great surgeon you are, whatever you are, never attempt a simple message, because I feel that in compromising in cosmesis, we do compromise the nerve injuries.
Yes.
Just to get that 3 stitches less or 4 stitches less, you compromise on the viability of peroneal nerve. I think such techniques and such papers should be flushed out of the arthroscopy.
Yes, absolutely. Fully agree with you, Dr. Roshan.
Yeah.
There is one question on the chat box, Dr. Rajeev.
Yes.
There is little confusion in that person's mind. He is asking the difference between, what is Larsen's technique, modified Larsen's, and what is modified Laprade. Because you first demonstrated modified Laprade, I think. So can you just clarify Larsen's, modified Larsen's, Arserio, and which one to use? You showed the last slide, but I think for the benefit of the person who's asking the question.
So I think classical Laprade, you make 2 femoral tunnel, 1 fibular tunnel, 1 tibial tunnel. This is a classical. Yes. You can use a single graft or 2 grafts, different variation. The modified way, you can make a single tunnel in between your lateral epicondyle and your popliteus. Same way, Arserio and Larsen, again, it depends upon whether they are making 2 tunnel in the femur or single tunnel in the femur. And if you see the retrospective study nowadays coming through this, and if you see the ISAPA's consensus also, so if you don't have too much of external rotation or posterolateral subluxation of the tibia, I think Larsen and Arserio is good enough to give posterolateral corner stability. So Laprade, for me today, is the indication is you have the dial test positive and you see the subluxation of the tibia also, posterolateral subluxation, and when you open the posterolateral corner, you can see the movement of the fibula. If you have a jumping fibula there, I think you should go for the tibia-based procedure. That will give a good stability in the posterolateral corner of your knee.
Right. I think that really gives very clear. This was asked by Dr. Abhijit from Nagpur, so I hope that clarifies your doubt. Any other comments?
About modified Laprade technique, I think Sachin Tapasvi has modified Laprade's technique by his way, the single graft technique. Yes. That is also a very good modification. He's been now, we started using that since last 1.5 years. And it looks very nice. In fact,
we have a video on that. I can share that later on the Arthroscopy Insights.
You'll be surprised when Rob Laprade visited Jaipur. Gilbert Moshe talk about that technique, and he demonstrated same technique, Sachin's technique, rather than Lapras's technique. The popularity of Lapras's Sachin's technique is a wonderful technique. But how do I remember which one works where?
Yes.
I think a simple PLC, the lateral opening, you should go for fibula base, two tunnel or single tunnel technique on the femoral side. But the moment you have rotary element, rotational element, I will always add Laprat technique or something or the other, because rotational stability will not be taken care by only
Yes.
fibula based techniques.
Right, right.
Yes.
There's one last question is if there is a rotatory instability, because of the technical difficulties, the tibial tunnel too is a challenge to most of the people because you have to resect. So any tips on that, Rajiv? Because people kind of compromise, and I've seen that and heard from, many people
Yes.
that they will just
So-
prefer the modified Larson's or modified Laprat, not
I
the
think-
modified Laprat, the Larson's or Arthur, and avoid the tibial tunnel. So any tips on how to make the tibial tunnel?
First thing, go for a proper good dissection. Dissect with the index finger between the common peroneal nerve, posterior aspect of the fibula and posterior lateral aspect of the tibia. Start your dissection at the Gardner's tubercle, and your direction of drilling should be from the Gardner's tubercle toward the posterolateral part of your popliteus groove or the posterolateral part of the tibia. You can use your PCL jig or ACL jig also to make that tunnel, or you can use a thin spoon also to make, because you are very close to the neurovascular bundle. And once you dissect, you make a large posterior breast flap. It's very easy. With the light, you can see everything in the posterolateral corner. So that is important, what Dr. Roshan was telling also, and I think its exposure is very important. No minimal exposure for posterolateral corner reconstruction. So dissect everything, dissect your anatomical structure, see the posterolateral corner, see the posterolateral part of the tibia, and then try to make your tibial tunnel.
Right, excellent. Any other comments, Dr. Gopinathan sir? Anything you want to add to this? So it's on mute. You'll have to
Sir,
unmute.
you are muted, sir. Please unmute.
Okay. Nothing
Yes.
more to add, but Dr. Bancha has published many articles saying that he will do everything arthroscopically, and LCL he does by percutaneous methods. He drills from posterior aspect to anterior aspect, but I'm sure that exposure is the most important one, and then you have to protect
Yes,
the DPN. And
Yes.
the youngsters should not get a message that a cosmesis will finally result in a disaster.
So I think to just stress what Dr. Roshan rightly said is that the first important thing is to expose the nerve. And doing methods like Bancha, what he has described, I would rather refrain from doing it. It requires a large experience, and then doing endoscopic things for posterolateral corner, probably you may not be able to get a robust repair and a reconstruction.
Pancha's technique of PLC reconstruction is popliteus and fibula. Fibula-based tunnels are not anterior to posterior; they are medial to lateral. They are transtibial fixation.
So
When you want to do the anterior to posterior tunnels and fibula, it's very difficult to do arthroscopic. You have to do ultimately open incision. And then why compromise on your peroneal nerve if you're
exactly.
going to do
One has to get a very robust repair. I totally agree, Roshan. Okay, so I think excellent talk, more clarity on PLC. Every time I hear a talk on posterolateral corner, it is a subject as it used to be a dark corner, but I think now fair amount of light has been thrown, but yet some shades of gray still exist. So, but after your talk, I think a lot of clarity is there, Rajiv. Thank you so much for making it so simple.
That's power of Rajiv.
Yes, Rajiv, RR. So we go to the last and the best talk, I'm sure, by Dr. Gopinathan. He needs no introduction. He recently conducted a great course which was held in Calicut, the Arthrocon 2025, which was a great success. And all you wanted to learn about shoulder, you could learn there. So thank you for that course which you held in Calicut. Congratulations on the success of it. And now we look forward to hearing from you about ACL with the anterolateral ligament injury. Now ALL is an accepted ligament. There was a lot of debate 5 years ago, but I think that is something which everybody has accepted. And the recent ISACOS also, a lot of procedures were described for the lateral extra-articular tenodesis, and I'm sure your talk is going to throw more light on that. So over to Gopinathan sir.
Can you see my slides?
Yes.
Thank you. I take this opportunity to thank the organizers for allowing me to present this topic in front of this august audience and all the delegates. Now, we have learned a lot about ACL. Everywhere we go, we talk about ACL. And then the contemporary results of ACL, as per the current literature, says that there is a high rupture rate. It's around 18%, persistent instability and 10 to 30% of cases, and the return of pre-injury level in high contact sports as well as in light athletics is only 60%, 50 to 65%. So this makes a huge question on us because we do ACL reconstruction, we discuss every time, and final result as per all this literature, you can see that in 2009, 14, 16, you do all the literature search, then we are sure that the pre-injury level of sports activities achieved only in 50% of cases. That means there is something we are missing in ACL. So we talk about the stability of the ACL reconstruction, and we talk a lot about the pivot shift, and we talk about the central structure which we are putting inside the knee should give rotational stability. But the rotational laxity and pivot shift, even though discussed very well, we don't discuss about the ALC, anterolateral complex. We talk about PLC, PMC, but many of the literature and many of the meetings and conferences does not discuss about ALC, anterolateral complex. Now, the better control of rotation can be achieved by extra articular structures like sleeves. We talk about the medial collateral, lateral collateral, PMC, PLC, ALC, or AMC. These are the structures which gives rotational stability. And when you put a dead, non-viable, non-vascular collagen into the knee and ask for rotational stability is too much to ask for from the ACL. So this is how we should discuss these issues in next meetings, in literature, everywhere. So how can a centrally located cord-like structure prevent rotational stability to the knee? So this is the concept. Now we are all aware that we concentrate more on sleeves more than ACL nowadays, but we don't talk much about ALC. That is the importance of this particular presentation. So non-contact ACL injury mechanism and high contact sports are different. If you have a sedentary person who does all activities of sedentary activities, simple ACL reconstruction may be enough. But for those with high contact sports, they really need a lot of rotary stability. So in 1879 itself, people have discovered that there is some structure on the anterolateral structure which gives stability. This is a capsulo-osseous structure in IT band, which acts as an anterolateral ligament, or some anterolateral capsular structure is giving rotary stability. The conflict of this particular aspect is that we talk about pivot shift, explosive pivot shift, grade 1, grade 2, 3 pivot shift, you do ACL reconstruction. But are we really addressing this pivot shift? Pivot shift is a rotational instability. So anterolateral rotatory instability, the rupture of the middle third of the anterolateral capsular ligament is critical for pivot shift. Just an ACL injury will not give a frank rotary or pivot shift positive. So the pivot shift positivity is mainly due to an ALC injury, not just because ACL is injured. So these are the literature publications supporting this particular point, and so many people have already discussed about the ALC and ALL, and the graph choice makes a difference. People talk about a double bundle ACL reconstruction and say that post-lateral bundle reconstruction will give rotary stability, but it has been proved beyond doubt that it will not give too much of a rotary stability, even if you reconstruct the post-lateral bundle and anteromedial bundle separately. So you need something outside the joint, extra-articular. That's how we talk about the anterolateral complex, anterolateral structures. So the biomechanics of the ALL is that if you just cut the ALL, the pivot shift is only grade 1. But if you section the anteromedial posterolateral bundle, then the pivot shift is grade 1 again. But the moment you cut the AM bundle as the posterolateral bundle and then cut the ALL, then the pivot shift become positive. So in an explosive pivot shift, just an ACL reconstruction is not enough. You have to do something on the anterolateral side. And that's the importance of anterolateral tenodesis. So anterolateral ligament is an important rotary stabilizing structure between 30 to 90 degrees of flexion, unlike ACL. So ACL is not the structure which gives anterolateral stability. So if you look at the cadaveric studies, there are literature supporting that there is existence of ALL and at least a good anterolateral structure should be there. There should be an ALC, anterolateral complex. So does the meniscus influence pivot shift? This has been already highlighted in the last presentation. If you have a ramp lesion or a root lesion on the medial side, then also you can have anterolateral instability. But the moment ALL is injured, it is your duty to reconstruct it or just do at least tenodesis. So who needs reconstruction? Most patients do well with primary ACLR with meniscal repair, but most of them are not high contact sports people and sedentary people. So ALL is injured to some extent in all ACL injuries, but repeat episodes of instability stretches out the ALL and the ALC and lateral complex. So does ALL reconstruction work? Untreated ALL leads to poor outcome in ACL reconstruction, ACLR. This is as published in most of this literature. So when there is an explosive pivot shift test, you have to do some extra-articular reconstruction. Whether you called it AL reconstruction or ALT, anterolateral tenodesis, it does not matter. You have to do something on the anterolateral side. That is the essence of this presentation. So the modified Lemire technique is a very simple technique, either as a part of ACL with rotary instability or during ACL revisions. Most of the ACL revisions, people nowadays are doing anterolateral tenodesis. And if you are doing it for revisions, why not for a primary explosive pivot shift positive cases? So in primary case also, you should address the anterolateral structures. That is, you have to at least do an anterolateral tenodesis. So improved stability when compared to the ACL surgery alone is advantage of anterolateral tenodesis. Originally, ACL alone was done even if rotary instability was there. So now people do anterolateral tenodesis for rotatory instability. So anterolateral structures are commonly injured in ACL injury. Anterolateral injury means anterolateral instability or explosive pivot shift positive. So anterolateral tenodesis plus ACL is the current method of treating explosive pivot shift and anterolateral instability, just like PMC or PLC injury. So ACL alone, there is a residual laxity in rotation and translation. Modified Lemire technique means normal laxity and stability to prevent rotary instability. So fear of the lateral compartment overstrain the lateral compartment. There is no evidence in literature to suggest all these things. So keep intra-articular stress as normal as possible. Keep the knee in neutral position while you tighten the anterolateral tenodesis graft, and then use only moderate tension. You should not use too much tension. Maximum tension you can use is 2 kg. So it should not be too much tightened. So modified Lemire technique should be done in selected ACL cases, ACL with gross anterolateral instability and pivot shift positive, explosive pivot shift positive, high risk of failure of primary ACL. So to prevent that, you can do ALT, and revisions almost always needs ACL. So anterolateral structures will have a protective effect on ACL reconstruction during rehab. So if your ACL graft has to survive, ALL or ALT will definitely help in that also. So the technique is very simple. Position the knee at 90 degrees as for ACL. You can use hip pad, thigh support, everything as for ACL. So distal foot should be for 90 degree and deep flexion. You should be able to move the knee. So surface anatomy is marked as Gerdy's tubercle, lateral epicondyle, and the fibular head. And expose the ITB. Make an oblique incision from Gerdy's tubercle to the lateral epicondyle, expose the ITB, and keep the limb in figure of position. This will help you to identify the LCL or FCL, that is a fibular collateral ligament, as a cord-like structure. So that's the method of easily identifying the LCL. So you have to harvest the graft, demarcate and harvest the graft 8 centimeter long, at least 1.5 centimeter wide, and it's a strip of the ITB. Leave the distal part attached to the Gerdy's tubercle and detach only the proximal part. Now you whip strip the graft into a cylindrical graft, then pass it under the LCL and prepare a femoral tunnel. You can use a suture hanger, you can all suture hanger or metal hanger or like a screw or a ligament staple, anything you can use. It is immaterial, but you have to do the fixation well. So identify the LCL, locate the femoral insertion of the graft. It is just posterior and proximal to the lateral epicondyle. It is important to identify this point for the correct tensioning and the isometric point. Remove the soft tissues and then pass a K-wire, and here we are using a screw. You can fix it any other device. So graft passage should be carefully dissect the interval and then lateral capsule for the from distal to proximal and preserve the joint capsule. In this bargain, you should not open the joint capsule. So thread the pass with bit pin and then put whatever screw you can put. The size is usually around 8 mm or 9 mm and 20 mm length. You can use all other devices you have just to fix the graft. So you need not always put the screw. If you want to avoid the tunnel, you can use other device also. And then close the ITB. So this is just a cadaveric and live surgery and demonstration on how you do a ALT. So this technique involves, again, you just open up the ITB, 8 centimeter long graft, that is from the distal part is attached to the tibia, and now you are going to whip stitch it. Now it's a flat graft, as you know, ITB is a flat structure, and you are going to make it cylindrical. And this diameter should be around 7 or 8 usually. And now this is how you identify the LCL, fibular collateral ligament. And then you dissect it out, never injure that. You should be gentle enough to dissect it out without injuring. Now the fixation point is just proximal and posterior to the lateral epicondyle, that is the upper attachment of the femoral attachment of the LCL. And you can use, as you use it for any other technique, you make a tunnel and identify and measure the diameter. Usually it is 7 mm or 8 mm. And then you pass the graft under the LCL. Now, in this bargain, you should not injure the LCL. Now, once the graft is passed, you can pass it through the eyelet of the bead pin, pull it through on the medial side, just pull it out, and then put the screws. When you tighten this graft, the knee should be in the neutral position. And also, you should not give too much tension. If you give too much tension, probably the risk of overstressing the lateral compartment and future osteoarthritis is there. But this lot of stress is not needed, lot of force is not needed in this type of fixations. So it gives some tenodesis effect and then restraint to over internal rotation, that is rotor stability. So this is the aim of this technique. During revision ACL surgery, almost everyone, we all use this technique. So also we should use it in explosive pivot shift positive, because we should understand that anterolateral complex is also an important rotary stabilizer for the knee. Just an ACL reconstruction cannot achieve all the final results. Probably we can reduce the failure rate in the ACL. This is a revision ACL. We have done a bone tendon bone graft for ACL reconstruction. And then hardly 20 to 30 minutes you will have extra to do an anterolateral tenodesis. This is not an ALL reconstruction. This is only anterolateral tenodesis. ALL reconstruction itself is a different topic and a different technique, but this is enough in most of the cases. There is not much of an implant cost, and the technique is very simple. Anybody can do it very easily. So this again, the graft is taken and it is whip stitched, and that is a LCL. You have to identify the proximal distal attachment, and then you should be careful enough not to injure the LCL. Now you pass the graft underneath the LCL, that is a LCL. So you should be careful enough not to damage this. This cadaveric and live surgeries are in different patients. That's why the direction of pulling the graft is different. One is on the left side, the other is cadaver was on the left side. This is on the was on the right side. This is on the left side. So this graft is pulled under the LCL, and then here the graft is attached with a ligament staple. We did not put the tunnel, because to avoid too much tunnel on the femoral tunnel, you can just use a ligament staple or a suture anchor, all suture, or a metal anchor or a peak anchor. Any of the devices you can use here. So in this technique, we have used a ligament stapler. This is a ligament stapler, and you just apply it. In very thin patients, the stapler may jet out and then create problems. In those cases, you can use a suture anchor. So the post-op rehabilitation is almost the same. Allowed weight bearing on day one. No limitation of range of motion. Knee immobilization is necessary for a few days. You can use SLR and crutch walking as you do for ACL reconstruction. There is not much of a difference between the rehabilitation after ALT and simple ACL. So untreated ACL, ALL injuries lead to poor outcome after ACL. These are the outcome studies which have been already published, where ALL is not reconstructed along with ACL. So clinical imaging, pivot shift 2 or 3, explosive pivot shift, Lachman more than 7 millimeter. There is a Segon fracture. And then these are the indications for ALL, ALT. And complications, when we talk about demonstrate the complications published in literature are lateral compartment osteoarthritis, but that will be there if you use too much of a force. Otherwise, it is a very simple surgery, and there is no evidence to suggest that there are many complications related to anterolateral tenodesis. So the debates on femur attachment, you can use any of the devices, and anatomical ALL reconstruction is a different technique. So to summarize my presentation, anterolateral complex, ALL, ALC, ITB, anterolateral capsule, and lateral meniscus and medial meniscus ram lesion, all this has to be studied well. So major role in pivot shift and anterolateral instability. ALL is often injured concurrently with ACL, and ALL reconstruction need not be always needed. You can get the same results with anterolateral tenodesis. So don't forget menisci and collaterals. Combined ACL with ALL reconstruction or anterolateral tenodesis reduce the graft rupture, reoperation rate, and in revision surgeries, we always use anterolateral tenodesis. Thank you for patient listening.
So thank you very much, Dr. Gopinath. Excellent talk. I think there are a lot of questions already. The first question they ask is, in primary cases, if there is a pivot shift, explosive or a grade 3, what we call pivot shift, should we always do ALL reconstruction, like not a reconstruction but a lateral extraarticular tenodesis? Is it mandatory?
Yeah. Nowadays, we are more towards ALT. The incidence of ALT in our practice has increased so much. From initial days, we used to do just anatomical ACL reconstruction. Nowadays, a few cases we did double bundle also, thinking that postlateral bundle will take care of the rotary instability, but they all failed. So nowadays, we add, when we are in doubt that ALC is injured or explosive pivot shift, then we always add anterolateral tenodesis. So incidence of the number of ALT we are doing has increased nowadays.
So what about the modified Ellison procedure instead of doing a modified Lemaire? Do you have any preferences or any thoughts on the modified Ellison?
Now, this technique is quite handy in our hands. So if a surgeon is handy in the other technique, you can do that. This is very simple. The implant needs are not there, and then this is a very easy technique. So we move.
Rajeev, any experience with Ellison, modified Ellison? Or Roshan?
Yeah, hello. Yeah, Parag.
Yes.
I have great experience with modified Lesion. In fact,
can you little elaborate on
I stopped doing the Lemaire around 8 years back.
Oh,
and
really?
I shifted completely to modified Ellison, because what I find is the rotary instability is on the between tibia and femur. So I have my own analogy. In fact, 2 of my students have published that data also. So the analogy is that the rotation happens between tibia and femur, and tibia is rotating with respect to femur. So if I had to do a fibula-based, tibia-based procedure, the rotatory force required for rotation is very less, which is on femoral side. If I do it, the force required is very, very high, because fixation is away from the joint. Here the fixation is very close to the joint. So the stiffness in modified Ellison is very, very less as compared to the Lemaire. The second analogy is the tunnel convergence, because whenever you're doing an ACL along with LET, very high chances that the insertion point for LET is very close or in the range of your femoral tunnel. So if you want to avoid that, the only way is to do it on the tibial side, because on femoral side, then if you're already doing a 9 mm or 10 mm ACL tunnel with all these grafts, then adding another 6 millimeter is like 16 millimeter of bone loss on that range. So to avoid that, I always do it on the tibial side with modified Ellison. So my analogy is a little different than others.
No, totally valid point, because one is that brings us to the point of fixation. If what Dr. Gopinath showed, you make a tunnel in the femur, that is probably a better way than a staple. But then for me, I do modified Lemaire, and for the fear of coalition, or exactly what you said, that there will be so many tunnels in the femur, then use a staple. So is using a staple a good enough option, Dr. Gopinath, or do you feel that probably an interference screw is better for the Lemaire on the femoral side?
But tunnel is not always needed. Even though tunnel is described, nowadays we just use a all suture anchor or a metal anchor. That is enough. That much is enough for the Lemaire.
That is enough?
That is enough for stability. Or maximum, if the patient is not very thin, a ligament stapler in the canal is tunnel is not needed.
Correct. So staple is good enough in your opinion, because that's what I use most of the times.
Yeah, that's a very good technique. That is enough. Tunnel is
Yeah.
not.
Roshan, how do you fix? Okay, how do you fix the Ellison on the tibial side? What is your choice of fixation?
So choice of fixation on the tibial side is 99% or 90% of the time is always a bias screw. And sometimes if the graft is short, I use the swell lock type of fixation so that I can get better swell lock type of anchor fixation so that I can get better fixation. But see, what I feel was on the femoral side, whenever you do anchor fixation, the rotary strength of this 7 millimeter or 8 millimeter strip of IT band is so high that it will make it very, very stiff. The analogy is that lateral side should not be stiff when you're doing an ACL reconstruction, because lateral side has a natural laxity. And to cope with that natural laxity you should not make it very, very stiff. In fact, there is a wonderful study by, I don't remember the author. He says that if you take the bigger size strip for IT band, you will create more stiffness. So they advocate less than 7 strip, not more than that. 6 or 7 millimeter strip is good enough to control the rotation of the femur on the tibia. If you make it a 9 or 10 strip, it will become very, very stiff.
Okay, and what is the direction of your tunnel on the tibial side if you use the interference
Tibial
screw?
side, lateral to medial, simple, behind the ACL tunnel. So your ACL tunnel is anterior, it's in 40% of the anterior width of the tibia, whereas this tunnel is going to be behind and posterior. So there is no way it can have a coalescence with your tibial tunnel. It's a very, very safe technique.
Right. And I think if there's any video technique you have on the Ellison, if you can share
Yeah,
there.
Ellison, I have wonderful videos. Next time, whenever you have, we can show that. Next time we can plan a
or if you can share
modified
it, then I
Ellison.
can put it on the group as well.
Yeah, I'll share it on the group. No problem.
I think that's a really fantastic session on the lateral extraarticular tenodesis. As they say, there are more than one ways to skin a cat, and we saw the modified Lemaire, which is now probably being used worldwide. But Ellison is also gathering a lot of momentum, and for the advantages as mentioned by Roshan, I think it is a good technique. But it will suffice to say that whenever we are dealing with the grade 3 pivot shift, we are dealing with revision scenarios, and as rightly shown in his talk, Dr. Gopinath emphasized about the anterolateral instability and the rotatory instability. Just doing the ACL is not enough. So I think we have come a long way, and in today's 3 talks, it has been very clearly emphasized that if the ACL has to fail, then there is a reason for it to fail, and it's not only the surgical technique. If your surgical technique is right, but if you missed a ramp lesion, if you don't really take care of the posterolateral rotatory instability as well as the anterolateral rotatory instability, if you ignore these, then the ACL for the first 6 months will do well, but then over a period of time it will stretch out and fail. So I think the title for today's webinar was the hidden lesions, and one has to really take care of all these lesions, and just doing the ACL nowadays is not enough. So I think it was a great session. I think we'll have some concluding remarks from Dr. Gopinath and then Dr. Roshan and finish for the day. Gopinath sir, any concluding thoughts, any message for our delegates who are online?
Last one point I would like to highlight is that whenever you do anterolateral tenodesis or Ellison or modified Lemaire, you overstrain the lateral compartment, there is a problem. As it is told, when the knee flexes, the more of laxity should be there on the lateral side. As you do in TKR, if you tighten on both sides beyond 90 degrees, if both structures are tightened, then that TKR is not going to function well. Like that in the knee also, whether you are scopy or you do ALT or Ellison technique or modified Lemaire technique, there should be some laxity on the lateral side, because lateral side of the knee is controlled by dynamic structures like the tensor fascia femoris, biceps femoris. These are dynamic structures. On the medial side, you have a static structure. Mostly it is a medial ligament, and there is you are dealing with a static structure with a dynamic structure. So lateral side should be lax. So if you overstrain the lateral compartment, then it's a problem. Whether it is Ellison technique or a modified Lemaire technique, a final outcome is the same. So otherwise, it's a wonderful session, and we should all remember that the sleeves are important. ACL plus sleeves. So if you don't concentrate on sleeves, just go on doing ACL in every case, the chance of failure are high. So you have to concentrate on sleeves. That is anteromedial, anterolateral, posterolateral, or posteromedial. That is a mistake.
Absolutely. Dr. Roshan, any last thoughts before we finish the
Yeah,
webinar?
that was a wonderful session. In fact, from ramp to LET to then PLC, I think a wonderful session. The Arthroscopy Insight is a very, very good program. And I'm very sure the juniors and upcoming surgeons, budding surgeons, the people who are interested in arthroscopy will always get benefited with such webinars. Thanks, Parag. Thank you for involving me. And see you soon on Friday at
Yes.
Mumbai.
Yes, looking forward. So, friends, thank you for joining. And this was a great session. I want to express my gratitude to Dr. IPS Oberoi, Dr. Rajeev Raman, and Dr. Gopinathan for joining in and giving 3 excellent talks. Thanks to Dr. Nicholas Antao and Dr. Roshan Wade for excellent moderation, excellent comments. I think Roshan really gave very good tips on the MRI for diagnosing ramp lesions and his thought process behind the Lesion technique. Very good tips there, Roshan. Thank you. And now, before I finish, I want to invite everybody for the Arthroscopy Academy meeting, which will be held on Thursday, Friday, and Saturday at Mumbai. There are pre-conference workshops at the KEM Hospital and post-conference cadaveric workshops. And the main conference will be held at Hotel Westin. So please register. We have already more than 750 registrations. Few seats are left. So I'm sure, seeing live surgeries is a great way to learn as well. And, from webinars also, it's a good way. So what we are trying to do is impart education. I think education is important. Arthroscopy is really gaining a lot of momentum in India. We have 4,000 plus members of the Indian Arthroscopy Society. So that shows the level of interest. So thank you. And thank you, Dr. Ashok and the OrthoTV team for really getting this to the people who need to see it. We appreciate your support for Arthroscopy Insights. And thank you once again. And with this, we end the webinar. Looking forward to seeing all of you at Hotel Westin for the Arthroscopy Academy meeting. Thank you. Thank you, Gopinathan sir. Thank you, Dr. Roshan.
Thank you, Parag. Bye.
Thank you, Dr. Ashok.